All right, it's now 8:01, so we'll go ahead and get started with our presentation today. So good morning and welcome everyone to Provincial Stroke Rounds. My name is Aline Burgoyne and I'm joined today by my co-host Sophia Gokam. We are the stroke prevention nurse specialists with the Champlain Regional Stroke Network, which is based at the Ottawa Hospital. Today's presentation is titled The Canadian TIA Score, How to Identify High and Low Risk Patients for Subsequent Stroke, which is presented by Dr. Jeff Perry. Before we hand it over to Dr. Perry, just wanted to go through a few housekeeping items. Today's rounds will be recorded and archived. A link to the archived recording and the presentation handouts will be emailed to you after the event. Please check that your microphone is on mute and remains on mute for the duration of the presentation. Use of the chat feature in Zoom is strongly encouraged for any questions that you have during the presentation. An interactive component will be held during the last 10 to 15 minutes, and we will have a question and answer period. Please type your questions into the chat box throughout the presentation, or when it's the question period, you can use either the chat box or the raise your hand feature if you prefer to ask your question in real time. You'll be called upon to unmute your microphone to ask your question. At the end of the session, we kindly request that you complete the evaluation, and the details, including an electronic link, will be provided at the end of this talk. Certificates of attendance will also be emailed after the event. Please fill in your name and keep for a future reference.
And so it's my pleasure to introduce Dr. Jeff Perry as your speaker today. Dr. Perry is a professor with the Department of Emergency Medicine at the University of Ottawa, a senior scientist with the Ottawa Hospital Research Institute, and the Research Chair of Emergency Neurological Research at the University of Ottawa. Clinically, he completed residency programs in family medicine at Memorial University of Newfoundland and emergency medicine at University of Manitoba. He subsequently completed emergency medicine research fellowship at the University of Ottawa and obtained his Master of Science in Epidemiology in 2002. Dr. Perry's publication list includes more than 190 peer-reviewed publications. His major research studies have been in vascular emergencies. This includes several large, multi-center, prospective clinical decision rule studies to improve the care for patients with headache, subarachnoid hemorrhage, atrial fibrillation, heart failure, and TIA. Welcome, Dr. Perry.
Thanks, Sophia. Thanks, Elaine. It's truly a pleasure to be here this morning. I'll just get my screen here to share. And there we go. Is that working correctly now?
You just need to change your display settings.
It needs to be changed?
Yeah, this in the center at the top.
Okay, sorry.
Just where the arrow is beside display settings.
Sorry. There we go. Is it going correctly now?
Yes, it is.
Okay, it's reverse of when we practiced it.
Of course.
All right. So good morning, everyone. It's a pleasure to be here and been invited to present to you this morning. So this talk is on the Canadian TIA score, and the TIA score is a tool designed to help you identify high and low risk patients for subsequent early stroke. So just a few things. I do not have any significant relationships with for-profit or not-for-profit organizations. I do receive a salary support through an unrestricted mid-career salary support grant from the Heart and Stroke Foundation of Ontario. And I do, I guess, sit on the guideline committee, I guess, for the Heart and Stroke Foundation as well. And this is their slide as far as the mitigating potential for biases. So the Provincial Stroke Rounds Committee mitigates bias by ensuring that there's no industry involvement in the planning of this education content. So the objectives for today are to review the science behind the Canadian TIA score, to identify high-risk features for subsequent stroke in patients with a new TIA or minor stroke, to learn how to safely stratify TIA or minor stroke patients as low, medium, or high risk for subsequent early stroke, and to compare the Canadian TIA score to the ABCD2 and the ABCD2I scores for the identification of TIA or minor stroke patients' risk for subsequent early stroke. So just to put things in context, so if you have a case, say a 56-year-old woman, 9 o'clock was in the morning yesterday, was seen well, 9:45, she's found by her family to have aphasia, right-sided face, arm, and leg weakness. They call 911, brought into emergency. By the time they arrive, the patient is now fully resolved according to the patient, feels completely well. You assess the patient within a few minutes, and you confirm through your history and your examination that yes, indeed, the patient has resolved, is completely neurologically intact and has no signs or symptoms at present. So the diagnosis here is fairly straightforward, that their patient's was having some cerebral ischemia. Now, how exactly they're classified can be variable depending on which definition is used and perhaps what images are being seen. But essentially, there's two main ways we can define this patient. The World Health Organization definition of stroke or TIA is time-based. They're both determined as clinical syndromes characterized by the sudden onset of focal neurological deficits presumed to be on a vascular basis, with the simple distinction of 24 hours. If it's less than 24 hours, it's TIA. Greater than 24 hours, it's a stroke. This is, although simplistic, is still what most places, certainly in Canada and around the world, use. If places have access to early neuroimaging, some are going on to the tissue-based definition. So here it's a brief episode caused by focal brain or retinal ischemia without evidence of infarction on neuroimaging. This is probably a better definition in terms of being more accurate, but it relies on neurodiagnostic testing, which usually isn't available because it usually requires, especially early on, would require an MRI imaging, which is certainly not readily available and probably is not truly needed necessarily immediately for these patients as far as their immediate care. However, irregardless of how which definition is used, both these people are both these definitions indicate someone who's had cerebral ischemia, and our management is largely the same. And the reason why I bring this up is just what I'm going to talk about going forward. We've used the WHO definition, but it would certainly apply to the Albers or the American Heart Association definition here as well, in that we did include both TIA or minor stroke where the patient was able to be discharged home and be able to still function and weren't having severe deficits. So I just want to put that in context before I go further. So back to our case, what is her risk of stroke in the next 7 days? Next, with that is, do we actually have enough information to decide? Well, we do know that TIA sort of identifies patients that are at high risk for a subsequent event. We know that up to 10%, certainly in recent years, could have a subsequent stroke within 90 days. These numbers are thankfully going down in terms of the frequency, but the graph illustrates here very nicely that the risk of a subsequent event is very front-end loaded. And it's about 7 days that this sort of curve starts to level off, and when the risk starts to sort of more plateau, or at least go down with much smaller slope. than over here. So certainly within the first few days up to a week that are the highest risk. So how do you identify that if the patient's at high risk for a subsequent stroke within that time period? And this has been something we've been working on quite some time, and it's led to what we've now created and validated, the Canadian TIA score, which we think is going to provide a very useful tool to try and help answer that question. So why is it important? Well, we do know that many of these, the TIA can precede up to 20% of patients with a stroke. It is an opportunity for preventative intervention. And we also know that existing scores are context dependent or have not been well validated. So we've been working on this for quite some time. Effectively, we've looked at what current management is. We've looked at, we've prospectively validated the ABCD2, which I'll talk to in a moment. We then went on to derive the Canadian TIA score in a patient group of almost 4,000 patients. We've surveyed both neurologists and emergency physicians to determine what important cut points would be. We've looked at the specific CT findings for stroke. And then most recently, which is what prompted the talk today, is we've recently validated the Canadian TIA score, which we published in the British Medical Journal earlier this year. So back in 2011 in CMHA, we published our work where we prospectively validated or attempt to validate the ABCD2 score. So when the ABCD2 score was created, it used predominantly retrospective data, at least the US-based information, and the work from that was more prospective was in the UK, but that was assessed by neurologists in clinic and was not in the emergency department. So the methods that were used were not as optimal as they could be. And because of that, we were finding some, or at least we postulated it because of that, we were finding some inconsistency on how it seemed to work. So this was the first prospective cohort that evaluated the ABCD2 score. And we did this in over 2,000 patients. And here we found, using the original cut point of greater than 5, that the sensitivity for identifying patients with subsequent stroke was very low. It only identified 31% of patients with subsequent stroke within 7 days. When we looked at the American Heart Association suggested target cut point of 5, we found that it still only identified just 95%. And also importantly, almost all patients were identified as being high risk at that point, with a specificity of just 12%. So we thought that something more could be done to better identify these patients. So we went on to prospectively derive a proposed clinical decision score or prediction score for identifying patients that would have a subsequent event within 7 days. Again, we chose the 7 days because of that curve I showed you, where really it was until 7 days that these patients were at highest risk. So we want to make sure we're identifying all of those patients that had a subsequent event within that first week in particular. So in this study, we prospectively enrolled almost 4,000 patients from 8 sites across Canada. And we developed a score that had 13 variables, so a lot more than the ABCD2, but it had a fairly good discrimination with the C statistic of 0.77. The variables included 9 clinical variables. So the first TIA in their lifetime was worth 2 points. The symptoms of 10 minutes or longer was worth 2 points. If the patient had a known past history of carotid stenosis, that was worth 2 points. If they're already on antiplatelet therapy, it was 3 points. History of gait disturbance was 1. History of unilateral weakness was 1. And history of vertigo was -3. If they had an initial triage diastolic blood pressure greater than or equal to 110. And if they had dysarthria or aphasia by either history or on the examination, this was 1 point. We also included investigations that were routinely done as part of an assessment. So we looked at if they had atrial fibrillation on their ECG, it was worth 2 points. If they had an infarction on their CT head, either acute or chronic, and if they had a platelet count greater than or equal to 400 or elevated glucose greater than 15. And this gave you a total score between -3 if they had just isolated vertigo, all the way up to 23 if they had everything else but no vertigo. Once we created this, we also want to know, well, what are physicians going to think about this? Will they use this kind of risk score? What do they think are appropriate cut points to identify low risk, medium risk, and high risk groups? And what would they propose to do at each strata? So we surveyed both emergency physicians in Canada as well as neurologists in Canada to try and figure this out. So this is the information for the emergency physicians, but the neurology results were very, very similar to these. And basically here we again want to find out if they would use it, if what their belief was on in terms of what was the face validity for each component of the TIA score, and very importantly, what are the appropriate risk strata for stroke within 7 days. And then we also want to get a bit of an idea of what to do at each step. So the methods basically about just under 246 Canadian emergency docs were surveyed, 250 neurologists. We basically sent out pre-notification letters, then 3 survey attempts, including a unconditional incentive in the first one, and then a 4th by registered mail. We had 41 questions, demographics, and wanted to get, again, to assess the face validity and cut points. And essentially what we found was the physician respondents rated most of them, each of these elements very high. The exceptions were the platelets and the glucose were low. Neurologists rated glucose higher, over 50%. And vertigo as a negative predictor, people were a little bit uncertain about. And that was the same with the neurologists as well. In terms of the risk groups, we identified low risk groups as being a less than 1% subsequent stroke rate within a week as being low risk. Medium risk would be 1 to 4.9%, high risk being 5 to 10%, and critical risk being greater than 10%. And the neurologists were nearly identical to this, except that they chose a 2% risk here rather than the 1% that the emerged docs predicted. And this replied to what 75% would agree to. So these surveys helped us to figure out that yes, they did endorse that they would likely use a validated score, that most of the elements they did have good face validity. The glucose, platelets, and vertigo were the 3 that had a little less buy-in. And then the risk strata were identified as low risk being less than 1%, medium 1 to 4.9, and high risk being basically 5% or higher. We essentially have since kind of consolidated the high risk and this critical risk group into one group. And then certainly actions needed. We did look into that, but I won't go into that here as far as what physicians suggested. So moving forward, we've now published the results of our study where we prospectively validated the proposed Canadian TIA score. And in this validation, we directly compared it prospectively to the ABCD2 and the ABCD2I to determine how well it functioned. compared to these two previously established scores. So the objectives of this study were to prospectively validate the Canadian TIA score in a new cohort of emergency department patients with TIA or non-disabling stroke. This was a prospective cohort study. We conducted at 13 high-volume urban Canadian emergency departments over 4 years plus follow-up afterwards. We collected data on all the components of the Canadian TIA score individually and as a whole. We also assessed investigations and admissions. Our primary outcome was subsequent stroke or carotid revascularization within 7 days. Our secondary outcome was subsequent stroke within 7 days. These outcomes were adjudicated by blinded adjudication committees that generally consisted of 2 stroke neurologists and 1 experienced emergency physician, and 2 of the 3 had to agree to the outcome before it was deemed to be an outcome. Our analysis included interval likelihood ratios with their 95% confidence bands, and as well as comparison of the area under the curves for the 2 scores using the DeLong method, and calculating the net reclassification indexes for comparing the different scores. Our sample size initially was based on 5,000. This was based on our secondary outcome, which targeted 93 patients with subsequent stroke within 7 days. Right. So why did we change? So we changed our primary outcome from the initial derivation to the validation cohort to be a composite of either early carotid revascularization or subsequent stroke within 7 days. And the reason why we did that was that there was certainly more emerging evidence that the number needed to treat was so low for patients with a hot carotid, where the carotid blockage was the cause of their event, that if we didn't include these patients, we would be misclassifying high-risk patients as being low risk, because some of these events would have been averted by intervening early. So that's why we did this. We didn't include other causes of stroke, such as atrial fibrillation. While certainly treatment's very important, it's not nearly as effective of a treatment with such a low number needed to treat as it is for carotid stenosis. So this is what our paper form looked like in terms of our study. We also, some sites used electronic, and many sites were able to replace the stroke prevention clinic referral form with our study form, such that it made the process of completing this much easier. So of 9,436 eligible patients who presented during this time period, we enrolled over 80% of the patients with 7,607. Of these, 183 had either a subsequent stroke or carotid revascularization within 7 days. This corresponded to an event rate of 2.4% by 7 days and increased to 4.4% by 90 days. So sorry about this. This is a bit busy, but if you can follow me here. So this is for all patients, and then this is the low-risk patients, the medium-risk patients, and the high-risk patients. And so, as you might expect, the patients with high risk were certainly older. There were more men than women. More patients arrived by ambulance, of almost half of the high-risk patients versus less than a third for the low-risk patients. The first ever TIA was more common in the high-risk patients. And the duration of symptoms, almost none of the patients in high risk, the symptoms last less than a minute, whereas many of them did last for quite some time and were much longer lasting episodes than the low risk patients. Altered sensation was not terribly helpful. More weakness, more language disturbance, lightheadedness was less common in the high-risk patients, more common in low risk. Vertigo, again, not very common in the high risk patients, but much more common in the low risk patients. And gait disturbance, more common in the high risk than the low risk. Looking at physical findings, we found blood pressure certainly is higher in the high risk patients, but not as much as we might have thought. Heart rate, no difference. Weakness being much more common. This is on examination. Altered sensation, again, not terribly helpful in distinguishing the level of risk between low risk and high risk. Not super helpful. Speech difficulty, much more common. Gait abnormality is more common. Dysarthria, again, more common to high-risk patients, as was pronator drift, aphasia, and abnormal finger nose testing. So all the things where there's hard neurological findings typically associated with a higher degree of risk. In terms of the past medical history, again, your typical risk factors were more common in the high risk than the low risk groups, including hypertension, high cholesterol, diabetes, ischemic heart disease, and known prior stroke. Interestingly, we did not get a signal with smoking, which was a little bit surprising, but basically that it did not seem to distinguish between low risk and high risk groups. Atrial fibrillation, much more common, as was peripheral vascular disease and carotid stenosis. In terms of tests that were done for our patients, so overall, almost 97% of patients in our cohorts, remember ours was a prospective cohort study, so we weren't able to necessarily mandate how the physicians managed these patients, but within our group of patients, almost 97% did have a CT head performed, and many of these demonstrated either acute or old infarction. Overnight, so 91% had an ECG done, which is a little lower than I might have thought, but still quite high. Very few had an MRI, so this MRI typically would have been within 90 days. Some of them would have it very early, whereas others would have it more delayed. And then in terms of vascular imaging, 57% had a carotid Doppler, and 27% had a CTA of the neck. In terms of how patients were managed, basically, so this here shows, again, for all patients versus their risk strata. And this is when they presented. So when they came in, about 43% were on an antithrombotic agent. So that could have been antiplatelets or anticoagulants. When the patients left, so medications on discharge, this increased to nearly 88% that were on an antithrombotic, with ASA being certainly the most frequently used agent. So in terms of how our patients did, so this is our primary outcome right here. So as I said, 183 patients had a subsequent stroke or carotid revascularization within 7 days. So when we look at the low risk group, this corresponded to 6 patients, or a risk of 0.5%. And then if we looked at the high risk group, this corresponded to 6% of these patients having a subsequent event. If you look at the secondary outcome, which is down here, so this is a subsequent stroke within 7 days. And here we found that there's 108 patients. So some patients did certainly have both a carotid revascularization and a subsequent event. We found here there's just 3. So just half of those 6 patients that I mentioned above here, half of these were categorized as in terms of the events here, that in the low risk group, half of those were carotid revascularizations and half of those were subsequent stroke within 7 days. And then again, it increased throughout. And then also want to highlight sort of in terms of to get a sense of our cohort. So just 5.8% of all the patients enrolled in our cohort were admitted to hospital during that index visit. These were spread out across the different risk groups. So low risk, high risk, medium risk, and high risk. Certainly there was more in the high risk group, but still fairly common for some in the low risk group. This just looks at the individual scores with the color classification of low, medium, and high risk. But basically, I've given you the collapsed level information, which is probably more useful than the individual level except that certainly different groups, different practice groups could certainly determine a different criteria based on their local practice. So if a group wanted to, say, use a higher cutoff, say less than 2%, then they certainly could go with a higher score to make sort of to define a low risk group than what we've proposed. I guess that's the one purpose of showing this slide, is that it is adaptable to different systems if they wanted to change the proposed cut points to other cut points. So looking at the interval likelihood ratios, so for our low risk group here, we found that the interval likelihood ratio for this strata was 0.2. So significantly less likely to have a subsequent event in that group. And then the high risk group had an interval likelihood ratio of 2.56. So this was for our primary outcome again for subsequent stroke or carotid revascularization. When we looked at the group that was for subsequent stroke alone, here we got nearly identical results, which again found much less lower likelihood ratio for those in low risk group and a higher likelihood ratio in the high risk group. When we compare the ABCD2 and the ABCD2I scores, so we used a few different techniques to compare these scores. So one was looking at the area under the receiver operating characteristic curve, or AUC, or the C statistic, however you want to call this. Here we found Canadian TI scores 0.7 versus 0.6 for the ABCD2 and 0.64 for the ABCD2I. Now the DeLong method is used to compare area under the receiver operating characteristic curve values using a statistical test to see whether they're significantly different. And here we did find that the differences in these curves were statistically significant, and with the corresponding p-values over here. So certainly statistically, I'd say it's different, significantly different. And I'd argue that clinically, this is very significantly different as well. So that was one method of comparing these scores. The other tool that other statistical techniques that we've used to compare the score, we're using the additive net reclassification index, and as well as the absolute net reclassification index. So essentially what these reclassification indexes do is they look at, okay, how would somebody have been classified if we used the previous score, and how are they going to be classified if we're using this new score, and how many times would they be reclassified in a good way? So that's the additive net reclassification index. The absolute is also looking at, how, okay, what about the ones that are now negatively moved? So if they were correctly reclassified or classified before, but now they're being reclassified incorrectly. So it more gives you a the absolute difference when you take in the consideration of better classification as well as those that are now less well classified, and this number can even be negative. So what we found when we compared the Canadian TI score with the ABCD2, what we found is, so if you look at here, this is for the group with a subsequent stroke or carotid revascularization within 7 days. We have the Canadian TIA scores for low, medium, and high risk groups, and the ABCD2, again, using the same sort of groupings. We found we were trying to aim for less than 1%, the medium risks are 1 to 5%, and then the high risk being greater than 5%. And that corresponded to these cut points. So -3 to 3 for low risk, 4 to 8 for medium risk, and 9 or more for the high risk for the Canadian TI score. And for ABCD2, basically it gave 0 to 5 was medium risk, and greater than 6 was high risk. And importantly, if the ABCD2, it again was not able to classify anybody as low risk, as less than 1%, which is, say, is one of the big advantages of the Canadian TI score, is that it is able to identify a big proportion of these patients that are actually at very low risk for a subsequent event, while still correctly classifying more of the high risk patients as being high risk. So we found that with the Canadian TIA score, we were able to reclassify better these patients by 12%. When looking at the ABCD2I, we found that this was still statistically and clinically significantly better at able to classify. And again, both at the low end and at the high end of the score point. So better able to identify low risk as well as the high risk patients. So quite a few points for discussion here. So first off, we'd say that the Canadian TIA score did accurately identify the risk of TIA patients, subsequent stroke risk for revascularization within 7 days. The Canadian TIA score did outperform the ABCD2 and the ABCD2I scores. And so individual healthcare systems can determine specific thresholds to make decision management. So we've come up with, or we as being the author group and the investigators, came up with cut points based on the survey work we did with Canadian emergency physicians and Canadian neurologists to come up with 3 pragmatic risk levels. These can be modified based on local systems, but we think that these are probably very pragmatic, appropriate levels within the Canadian context, certainly, where they've been endorsed by the emerge physicians and the neurologists. But it can be modified to make some decisions. And then we suggest that local groups determine what their suggested care will be for these different groups. So based on our survey work and what we've been talking about, an example of this might be that low risk patients can be safely discharged following a careful emergency department assessment, which would typically include an ECG, CT head, and basic blood work. And then they could have more routine kind of follow-up within the system, given that they're at a very low risk of subsequent stroke and definitely subsequent early stroke. The moderate risk group may basically undergo some additional testing. So we typically think that this would include vascular imaging, looking at their basically probably doing a CTA within their initial emerge visit, if that's feasible in the practice location. If it's not, it might be finding a way to expedite the vascular imaging so that it is done very early, so that they can have that assessed, as well as making sure their antithrombotic therapy is further optimized, and that they have early specialist follow-up, so that they can still have quite aggressive therapy and management, recognizing that they are at higher risk than the low risk group. And then high risk group, certainly I would advocate that these patients should be treated very carefully and likely managed with consultation of a stroke specialist during their actual initial index visit, to make sure that everything that can be done is being done, and that they to manage them optimally, so that we minimize their subsequent stroke risk. And that would certainly include vascular imaging, optimizing their antithrombotic therapy, but also carefully considering other testing modalities, such as, or even possibly admitting the patient, or at least getting some kind of Holter monitor on these patients quickly, possibly getting an echocardiogram done early, and getting some other tests done, which are sort of patient specific, but further testing done and assessment done immediately, rather than having a delay. So a few limitations of our study. Well, this was still an observational study, as I've mentioned. So there was definitely some variation between physicians and centers regarding their testing, management, assessments. We did try to mitigate this by doing so, and I would also say also some variation with the diagnosis. So certainly many of these patients would be stroke mimics. They were being called TIAs, but this is basically reflecting real practice. And we thought it was very important to still include these stroke mimics in our study, so that our study would have real world applicability. Now, for our subsequent events, though, we did have very rigorous adjudication. And so we were able to have stroke neurologists and the one experienced emerge physicians blindly adjudicate these cases, so that we did determine if they had a subsequent event with a lot of rigor. So we're quite comfortable that all the subsequent events were true subsequent events, but the certainly some of the initial events might have been or would have been stroke mimics. We did not specifically adjudicate the side of the carotid stenosis for which they had an intervention to see if it correlated with the symptoms, but presumably the treating physicians would have done so and not have intervened unless it was appropriate to do so. We've not yet completed a refinement step, so we are trying actively right now to see, because we do have 13 variables. We recognize this is quite long, and we are trying to see if we can reduce this, and while still maintaining the accuracy with a slightly smaller condensed model. But this work is ongoing. And unlike some other emergency conditions where we have prediction scores or clinical decision rules, the Canadian TI score will not give a 100% sensitive model to direct care, but rather one that identifies high, medium, and low risk patient groups. And the treatment will be more center or specific rather than being universal. So in conclusion, the Canadian TI score identifies the risk of TI patients for subsequent stroke or carotid artery revascularization within 7 days. It is anticipated that using the Canadian TI score will optimize resources to improve decisions on hospitalization, investigations, and prioritization of specialist consultation, which we believe will improve patient outcomes. Thank you very much for your attention. I'm happy to answer any questions.
Thank you, Dr. Perry. Excellent presentation this morning. So there are a lot of questions in the chat box, so I'll go ahead and get started with those. And if anyone has any questions that they would like to ask out loud or have dialogue, certainly please feel free to raise your hand and I'll call upon you to unmute your mic.
I just want to point out that the raise your hand feature can be found under participants. If you click on that, you'll see the icon.
Thanks, Sophia. So the first question comes from Dr. Timpson. She's wondering if vertigo as a presentation is limited to isolated vertigo or vertigo even if other symptoms are present.
Yeah, so the vertigo in our score is vertigo, like any vertigo. So it's not isolated. If the person has isolated vertigo, they would end up with a score of -3, which has an extremely low probability for a subsequent event. If they have other findings, that will, of course, increase the risk and could certainly put them into a medium or a high risk group, depending on what those other signs and symptoms and risk factors are.
Great, thank you. The next question comes from Donna at the Toronto Stroke Network. She's asking if you can comment if history of severe migraines or headaches was considered a screening question.
So no, it was not. And certainly we do know that migraine is a common stroke mimic. We did not specifically look at patients if they have a history of migraine or to tease that out, but we were able to, I guess, again, in clinical practice, we often, I guess that comes into our decision-making to a certain extent if they have a history of migraines, but we're still faced if someone has acute neurological symptoms, faced with the idea, okay, is this patient likely to have be at high risk or low risk for subsequent stroke, in particular, if their symptoms resolve, so that we're trying to make decisions on how to care for them. If they're having active ongoing symptoms, most of these patients will be referred to a neurologist for further care immediately if they're having ongoing symptoms, whether it's thought to be migraine or not. Certainly if you have somebody who's has an acute neurological deficit, most emerge physicians anyway would err on the side of caution and have a specialist and neurologist involved immediately.
Okay, great. So next question from the chat box. I see there's no mention of ocular symptoms, comes from Ann Cayley, either monocular vision loss, diplopia, etc. These patients represent about 10 to 20% of our referrals. In our TAMS unit at Toronto Western, some of these patients have had strokes seen on early MRI, which is done within 1 to 2 days of referral. Why were these patients excluded?
So they weren't excluded. We initially in our derivation phase, we had diplopia, we had vision loss, visual field deficits, we had monocular vision loss, and we had all these, all of those sort of both on exam findings and history, if you're able to have it collected. They just didn't end up coming into our models. They weren't deemed as important as the variables that we collected.
Next question from the chat box is from Malaikai Mubungi from Toronto Stroke Network. Is there any information that looks at patient risk and hospital length of stay and or admission rates? So
we certainly did look at admission rates, and we found that, again, it was just about less than 5% of our cohort, both in the derivation and the validation studies, were admitted. So certainly most of the patients in the sites that were collecting or enrolling patients managed these patients as outpatients. So we did collect that information. For length of stay, we have not calculated that. It's getting very long in emergency departments these days. We didn't specifically collect that, and we also, although we have the data, we're still going through some of these data points, because we collected quite a lot of data on these patients, but we are still teasing through some of the time to see neurologist information, how long till they saw either a neurologist in consultation, or in the stroke prevention clinic, or in a general neurology clinic, and we're actually currently teasing through some of that data now. I should mention that Malika actually worked on this study quite some time, or earlier iterations of this study. So hello, Malika.
Mm. And the last question in the chat box is from Colleen Murphy. Realizing that Canadian TIA score was used in ED, can this tool be used by stroke prevention clinics to help with triage?
I would anticipate yes, and certainly the most of the patients we see in emergency departments are sent on to stroke prevention clinics, and certainly I think that this tool will be able to, as long as the stroke prevention clinic has access to the signs and symptoms, then they would be able to better triage which patients need more urgent assessment. So if you have someone who's being referred on who's high risk or even medium risk, those patients should be prioritized over patients that are clearly low risk patients, who will likely have a very good prognosis, and certainly over the short term, whereas these medium and high risk people have a much higher risk of a subsequent event, and the earlier that they're seen and investigated and managed optimally, they're less likely, as we know from the Express and the SOS studies and other work, that we are able to lower their risk of subsequent stroke by optimizing their management.
Great. So Dr. Silver, you have a question?
Yeah, thanks. I think this is a great addition to our tools to kind of select patients that need more advanced workups and need to be seen urgently. Just a few points. I think the big problem with the old ABCD2 score was, and it's probably relevant to this as well, is that you have to have focal neurological symptoms. We used to get a lot of referrals, or still do, into our stroke prevention clinic and TAMS, that they have the age criteria, they have hypertension, they have diabetes, which gives them a high score, but they really didn't have clear focal neurological symptoms. They were a little bit lightheaded, or they're a bit confused, but there was nothing to say that they actually had a TIA or minor stroke, and they're being given a high score just because of these risk factors. And I think your score has removed those as giving a lot of points for just the fact you have diabetes and you're 80 years old. So that's a great addition. The one thing is that I think that imaging is still the king, and we talk about the fact that, yes, you look at the plain CT, but the current guidelines for the workup of a stroke patient, even including the emergency department, is to do a CT-CTA. Now, I think when I talk to my radiology colleagues, there's probably a little bit of over triage towards doing a CTA on every patient that walks in into the emergency department with a little bit of neck pain or a little bit of dizziness. But truthfully, when you do that CTA, as opposed to, let's say, a carotid Doppler, and you get the entire vascular anatomy, we pick up a lot of things that when initially you assess the patient clinically, you said, well, this is really a low-risk TIA, until you do the CTA and the patient has a high-grade stenosis, whether it be extracranially or intracranially, or they have severe intracranial athro. And sometimes you're kind of surprised. We had a recent patient who was rather young, who had critical carotid stenosis, at the age of like 49. So I think adding the CTA is important. I think what would be helpful is to use this to sort of say, which patients don't need a CT. It's almost like the the ankle rule that you guys developed. We need something to say, okay, this patient does not need further imaging because they don't really have anything that puts them at risk at all. The final thing in terms of, and Kaylee mentioned, I think is important, and you've emphasized this, that this is a tool and you can't use it as the only way of assessing patients. For instance, the vertigo patient, if you have vertigo with other features, let's say you have vertigo, diplopia, and ataxia, that's very different than isolated vertigo. I think everyone agrees that isolated vertigo should be like -10 on your scale. But on the other hand, once you add other focal vertebral basilar or brainstem symptoms, that probably is different. And when you're creating a scale like this, you can't have all these nuances. So keep in mind that when you're taking that history, or at least when you're looking at the referral in your stroke prevention clinic, look at the nuanced cases, because there are cases that are really important that might have a low score, but just by the symptoms that they're having are probably something that needs to be seen quickly.
Yeah, and so certainly, I certainly agree with you, right, that the isolated vertigo, our study and other studies have established that these patients are extremely low risk. The question is it truly isolated, and trying to determine if there's other risk factors. And certainly with our study, we did find that that generally the patients who did go on to have subsequent events had other findings and other risks, so that their score was not just -3. They were picked up because of other features. As far as your comment about the vascular imaging, certainly vascular imaging has really changed the management of TIA and stroke and cerebral ischemia over the last 20 years anyway, but especially in the last several years, where it is becoming a lot more available and helpful to characterize what's going on. But within our study, I would like to highlight that of the patients we enrolled, only 3 of the low-risk patients went on to have carotid revascularization within 7 days. So that was of 1,242 patients, only 3 of those patients actually were found to have something critical enough to go on to have it revascularized. So while I do agree that it is possible to, and we will find in medicine, nobody sort of fits into one box, and we do need to keep our minds open and to think about things. The risk with the low risk group, or the probability of finding something that you're going to intervene on in this low risk population, is extremely low.
Yeah. The problem with that is that you're focusing on carotid revascularization, but I guess that's subsequent stroke or carotid revascularization.
So subsequent stroke or revascularization, there was 6 patients. 3 of those were carotid revascularizations.
Yeah, but remember, we're looking at not just the neck; we're looking at intracranially as well, and again, it also depends on your population. Like if your population is non-Caucasian, they have a lot more intracranial disease, and we pick up, patients with, middle cerebral artery stenosis, intracranial carotid disease, internal carotid disease that are really at high risk. So, yeah, no, I agree that it really depends on. It gets super complicated in terms of the combination of symptoms and radiological findings. But if you're going to do a CT and you're in the emergency and the patient is not just someone that has like trivial symptoms, just do the CT CTA in the emergency, because that will discriminate and bring out patients that you're going to miss and send home. And where we get sued is when we have patients with more juicy TIAs that we send home, and then of course their risk is so high in the first few days that if they're not seen like within that 24-hour period and they have a stroke after you've sent them home from emergency, those are the ones that kind of come back to haunt us sometimes. So
No, and certainly, I mean, I certainly do agree that and that the juicy ones or the higher risk patients absolutely 100% need to get imaged. I guess where I'm not as certain is these lower risk, because a lot of these lower risk patients don't necessarily have speech, often don't have speech or any motor findings. They're more sensory, vertigo, a bit of lightheadedness, or these kinds of things. And a lot of them, I would argue, ultimately are probably more stroke mimics than true TIAs. And so where we sort of indiscriminately imaged these patients, even though the emerge doc's calling them a TIA, we know that many of these low risk patients are going to ultimately be seen by the neurologist and deemed not to be a TIA in the first place. So if we indiscriminately image these patients, we're exposing a lot of patients to radiation, contrast, blocking the emerge department so that things are going slower, slowing down the time to run stroke codes because the scanner is busy with someone who doesn't actually have it, even cerebral ischemia. So I think that there should be some discretion, certainly, especially in these low risk patients, where I don't think that all of them need, and many of them don't need vascular imaging within the emerge department, but they certainly, you need to use some clinical judgment. I wouldn't just say use the score. I'd say you use your clinical judgment, and if especially if it's more of a motor or speech deficit, certainly my practice would be to image those patients. But the ones where they're low risk and they're not motor or speech deficits, I would not image those patients in terms of their vascular imaging, because we can slide someone in and out of the scanner and get them out the door very quickly. Whereas, because most emerge docs will interpret the CT head themselves and go, but for the CTA, that's a skill set outside for the emerge docs. They're going to require the neuroradiologist to interpret that.
Yeah, no, I agree completely that you want that score, the really low ones that you shouldn't be doing the imaging. That's why I said you almost need a rule to say, if your score is this low, don't image them.
Yeah, and we are trying to come up with better evidence to specifically answer that question too. But that's still work in progress.
Great, so we are over time. There was one last question from Dr. Kozabone, if you're willing, Dr. Perry, to answer it. So Dr. Kozabone asks, do you have any information on final etiology of stroke events with more fulsome workup in your cohort to better understand the moderate high-risk groups? Antithrombotics seem to have been managed in emerge, but still moderate high-risk groups had events.
So certainly we are still looking, I guess, at teasing things out a bit more, but the antithrombotics, I would say, certainly are not fully optimized. We do know that we've just looked at this data separately here, but the patients with atrial fibrillation in particular are certainly still not being optimized within Canadian emerge departments. That's certainly something we've clearly defined. So that's one area. Even the antiplatelets are not being still as optimally prescribed, and we still have over 10% of patients that aren't on any antithrombotic agent, which, if you're calling it a TIA or a non-disabling stroke, I find very surprising that you would at least start an antiplatelet agent at the very least. So we do know that those are not being optimized, and we also know that many of these patients that the carotid revascularization. So as I said, there was 84. I did present this but didn't highlight it, but there's 84 that were intervened within 7 days. This went up to 156 within 90 days. So these patients are still being identified as having critical hot stenosis, carotid stenosis, yet half of them aren't being intervened within this first week. So there's certainly a lot of room, I think, to improve on that, which may improve our outcomes.
Excellent. So thank you everyone for joining us today. As a reminder, we ask that you complete your evaluation to help us plan future events. Suggestions for future topics are also welcome in your feedback. So there will be a QR link that will be sent to you, as well as an email with the evaluation. And the QR has been posted up now if you see it. So you can use your smartphone and just activate that evaluation form right now if you're interested. Our next provincial stroke rounds will be held on Wednesday, October 6th. And this will be hosted by the Southwestern Ontario Stroke Network. And the topic will be community life after stroke programs. Thank you everyone for joining us today, and have a safe and happy summer.